Well, welcome. Welcome to our webinar entitled Navigating the New Global Health Landscape. Glad to have you with us today. Appreciate you taking time out of your busy day, or at least for some of you, taking time away from your vacation to participate with us live at this webinar. We've got a bunch of people with us today. So first want to say that the ground rules, which are your microphones are going to be muted. But if you've got a question, raise it in the Q&A or the chat along the way, and we'll try to either hit the questions along the way, depending upon what they are and whether they're relevant to what we're talking about at that moment, or we'll do our best at the end to answer any of the questions that have been raised. Do we have a poll today, Samantha? I can't remember if there is a poll today or not to gauge the audience's background. No poll today. Okay, no poll today, so we're going to go on with that. So my name is Les Trackman. I'm the managing director of Purview. Many of you know Purview as the platform that provides remote or virtual second opinions. Many of the people in the audience today are using Purview in their hospitals. But today we're going to talk more about not about the technology itself, about the issues associated with navigating the global health landscape and some of the new things that are going on in that landscape, the evolution of what's happening in the landscape. Similar to what we encounter in the US with licensure, we certainly have licensure issues for providers who are providing some of these opinions to patients that are located outside the US. And we'll talk about that a little bit today, but there's more than that has to be handled. We've got a lot of additional complexity that gets raised in the international arena. We have language issues, we have data residency issues, we have cultural issues and other considerations as we go along the way. So today we're going to focus in on those, most of all of what's changing in the global marketplace. And to help us navigate with this complexity, we've got two friends of Purview with us today. Appreciate you participating. We've got Jarrett Fowler of NCHL and Bill Ferrer of Hogan Lovells. Jarrett, first I'll introduce, is the Senior Director of Strategic and International Initiatives at the National Center for Healthcare Leadership. You may know him better as being the leader of USCIPP as well. And they provide lots of opportunities and lots of assistance to hospitals in their navigation of the international markets. And Jarrett leads a lot of delegations that go abroad there. So we'll get a lot of more information from Jarrett along the way, some real hands-on knowledge and experience that he's got. And also with us is Bill Ferrer, who's a partner with Hogan Lovells, where he heads up the firm's global governance, contracts, and education practice. So a big set of responsibilities at the firm. Bill helps companies, universities, hospitals, and academic medical centers all navigate the international compliance and government space. He guides companies in telemedicine programs, and he's an overall knowledge font for information about how to do these virtual or remote second opinions outside of the United States. So, Jarrett, if you wouldn't mind, please give us a more detailed introduction about NCHL and USCIPP so that the audience will understand that.
Sure. I'd like to thank both my Purview and Hogan Lovells colleagues for the invitation. And I'm happy to share a little bit more about NCHL, the National Center for Healthcare Leadership, as well as the US Cooperative for International Patient Program. So NCHL, it's a nonprofit organization based in Chicago that proactively creates platforms for industry influencers to connect through different innovative channels, evidence-based data and insight. Those are our bread and butter, the creation of best practices. We have several different membership programs. One of them is the US Cooperative for International Patient Programs, which is a consortium of about 60 American hospitals and health systems, all of which have a focus on international work. So they all have international patient programs, and almost all also do cross-border collaborations, international telemedicine. And we function essentially as the industry consortium for US hospitals that are doing international work. And I've been with the organization about 10 years.
Since you were a teenager.
Well, thank you so much.
And Bill, would you do us an
Sure.
introduction for Hogan Lovells, please?
No problem. And thank you to everyone for joining us today. And Les, thank you, and to Purview for hosting us. And great to be back on the webinar circuit with my friend Jared Fowler. So great to be together again. As you said, Les, so I'm a partner with Hogan Lovells based in Washington. I've been with Hogan Lovells for the past 20 years. And I head the firm's global government contracts and higher education practice. So my work centers on advising colleges, universities, hospitals, academic medical centers, and research institutions on essentially planting and growing both academic and healthcare projects around the world. So that work has taken me and my colleagues to everything from HIV/AIDS projects in sub-Saharan Africa to starting new hospitals in the Middle East to capacity building projects in Central America. And then, obviously all the cross-border telemedicine that has become a very active piece of what we do. Of course, the Middle East is very hot right now, so I'm in that part of the world quite a bit, working on all sorts of public health consulting and
Of course, the
advisory
Middle East is
projects.
hot right now. It's summertime.
Well, it's hot. It's hot in many ways, but yes, we want to focus on the public health piece of what's going on there. So look, I'm a lawyer, right? So I see these projects from the front end risk management and risk mitigation standpoint. Then in preparation of all the contracts and the transactional documents, then in negotiating with foreign hospitals and foreign governments, and then all that the back end, the sort of calamity or catastrophes that sometimes come up in that area, and we try to resolve those quickly and efficiently. So we'll sprinkle some of that into our discussion today.
Great. Thanks, Bill. So why don't we start out with what's hot? What are the regions that USCIPP is focused on because there's opportunity there? And maybe what are the regions that used to be hot that perhaps aren't as hot these days? I don't know who wants to start. You want to start, Jared?
Sure. So I will say that in terms of like where we focus our time and attention for business development work, telemedicine due diligence, the Middle East, the Gulf, Saudi Arabia, UAE, Qatar, Kuwait, always of interest. Many of our inbound patients come to the US from those markets, as well as interest in select Latin American markets, Chile, Costa Rica, Panama, Dominican Republic, and some Southeast Asian markets too, I think are of high interest, especially to many of our West Coast hospitals. I'll give Bill the answer what used to be hot, or the opportunity to answer the what used to be hot question.
Yeah, well, let me preface all that by saying, it has been a true pleasure collaborating with USCIPP on all of the countries and the regions that you mentioned, Jarrett. And we will, of course, continue to collaborate as some countries become of more interest than others. Um, in many ways, given geopolitics, as China's star has fallen a bit over the past several years because of all sorts of things that are outside of our control, right? The Middle East is rising. And so, Jared, as you said, it's very clear that Saudi Arabia, UAE, Qatar, and that part of the world is in some ways stepping in to drive projects, drive public health infrastructure, drive opportunity that previously had been sucked up by China and absorbed by that part of the world. So it's not to say that there isn't interest in Asia and in China. There certainly is. And I think that interest will remain steady, but it's become much, much more complicated and fraught to do business in any way in China, especially if you are an organization that is receiving US government funding for whether it's grants, contracts, or other projects, because the scrutiny, as you know, that's being applied to any China collaboration these days, especially if it involves scientific or research collaboration, it is beyond what we've ever seen in the history of US-China collaboration. And it is unfortunate in some ways, given the way that that medicine and scientific research ought to proceed, which is in a truly worldwide, global, collaborative approach. It's not that from a politics perspective, and so I really do see a lot more interest in the Middle East and in select parts of Central and South America, as opposed to mainland China.
So is there, that's really important information, I think, to share with this audience, but is there any change in what we always refer to as matriculation? So the ability of patients who get an opinion overseas from a US based facility or provider to come to the US? Because ultimately that's really
Yeah.
what the pot of gold is, right? Is treatment in the US. Is that changed now?
To be perfectly honest, as long as we're talking about programs that are focused solely on patient care, and not focused on research or scientific discussion in any way, many of those programs are continuing, whether they're telemedicine or remote second opinion or recruiting patients to the U.S. Those programs are continuing. There is, at least for now, not the same regulatory scrutiny applied to those programs that we have seen in years past. That said, or that we've seen for scientific programs. That said, I think in any relationship that a U.S. hospital or provider is going to have with a Chinese hospital or provider, one has to be extremely careful by doing your appropriate diligence on that hospital, on that Chinese provider, on that, even on the patient, to ensure that we are inviting to the U.S. individuals who are appropriately allowed to be in the U.S. for the reason they say they want to be in the U.S. And of course, just getting to the U.S. these days is much harder when you're coming from China than it used to be. There's a lot more vetting going on in the visa process than has been in the
And there are
past.
fewer flights, fewer direct flights. We used to have a daily direct here between Beijing and Chicago and Shanghai and Chicago, and now we don't.
Yeah. And one has to be careful with the technology, right? I mean, especially telemedicine, it's all digital technology, and there are technologies in China, there are providers in China that offer telecommunications equipment which are completely off limits to U.S. users, in especially U.S. organizations that are funded by the U.S. government. So lots to be careful about in doing that kind of business these days.
Okay, great. Again, awfully good information. So let's branch a little bit into the sort of some of the meat of the issues, things like licensure, data residency. So Jared, do you want to hit generally what those issues are that you work with a lot of your clients to try to help them overcome?
Sure. So it might help for me to paint a bit of a picture as to how we support our member hospitals who are trying to go about understanding how they should approach international telemedicine and remote second opinion services. So we, in 2019, several of our member hospitals got together with us, and we had collectively the idea to try to put our resources together, the hospital resources together, to conduct legal due diligence work for a number of different international markets that all of the hospitals, many of them were working in the same markets, interested in the same markets. So rather than duplicating their work, they came together to agree upon some commonalities or some common matrix, rather, that different areas that they wanted to know about to assess whether there is a business case, what is the risk for providing telemedicine and remote second opinion services to a number of different markets. So rather than do it on their own, they pulled their resources through USCIPP. We did an RFP to several different law firms, and Hogan Lovells submitted the best one. And we've been working with them ever since. I've conducted 25 different legal due diligence or analyzed 25 different international markets. And so when we developed this sort of standard due diligence matrix, I will say that, and Bill, feel free to chime in here anytime. I will say that what we are providing is a general assessment. It is not the deepest dive into each of the markets, but it is enough to help our member hospitals understand whether there is a business case, whether they can provide this or that service to X market. So our standard set of questions looks at a number of different things. So what regulatory bodies are responsible for overseeing telemedicine and the provision of remote second opinions, practice of medicine, defining direct patient contact in both virtual and written interactions. Does that differ between states and provinces? Defining telemedicine or telehealth. Does audio only or email communication constitute telemedicine or telehealth? Looking at, are there differences between, for remote second opinions internationally, if it's peer-to-peer or direct to patient? Does it matter if the patient is there or not? Licensure, marketing, any restrictions on that? Let's see, any patient data privacy considerations, looking at patient consent. And then we asked Hogan Lovells to do a high, medium, low sort of general, what is the likelihood of enforcement to the various areas that I just described. Bill, any further color that you'd like to provide there?
I think you put it perfectly, Jarrett. I mean, the diligence that has been done on these, what is it, 25 countries now.
25.
It is, yeah. I mean, it is certainly a starting point. It is by no means intended to be the ending point, because every U.S. hospital's precise facts are a bit different. And every US hospital's risk tolerance and risk appetite is a bit different. And so, Jarrett, you're exactly right. This is a really good place to start. And it's a good place to start because resources have been pooled to get to a fundamental understanding of the basics in a particular country. And then you can use that to take it a little bit further, depending on the precise nature and the precise interaction and the model and structure of the program, the telemedicine or RSO program that you, the US hospital, are pulling together. And in terms of how we do this, right? I mean, as a global law firm, and we've got 50 offices around the world, it's a very large international practice in the life sciences area. So we're well set up for it. We're easily set up to do this sort of diligence work. And in those in those countries where we might not have an office, we have a network firm that we work with on telemedicine matters all the time. So, I mean, we've probably hit 80 or 90 countries at this stage in terms of assessing the telemedicine opportunity and doing some diligence around whether it's licensure or doctor to doctor or direct to patient style service lines. And then we work closely with our teams in these countries to curate responses to the questions that Jarrett mentioned. So everything from what is the regulatory body that handles telemedicine in the country to do we need any sort of local registration, licensure, or other to do a direct to patient or doctor to doctor style program in these places? And you'd be surprised at how the answer varies from country to country and how important it is, of course, then to have that local real-time perspective on how these regulations are evolving. And they are evolving. They're not static like they were 10 years ago. They have very much developed with the pandemic and continue to develop.
So maybe we can unwrap this a little bit, because I think it would be really helpful for our audience if we could let's do a case. So a hospital decides that they'd like to expand internationally and has some idea of the geography that they'd like to go into. How would they go about trying to figure this out? Is that something that USCIPP can initially help with? Are your 25 different due diligence areas done because those are more inviting or more receptive to what we're trying to do?
I wouldn't say it's necessarily because they're easier. I think these are markets that often our member hospitals get patient referrals from. So we've done a lot of work around Latin America, honestly, probably half of Latin America by this point, and around the Gulf and China. But these are markets that our members are interested in knowing more about. And I think being able to analyze and look at the diligence work that Hogan Lovells and their partner firms and their folks around the world put together is a really good way to understand and go about, it's an entree. It's a really good entree, I think. Bill, what do you think?
So it's a starting point, but not an ending point, is what you're saying.
Right.
At a minimum, but it's a really helpful starting point, right? Because you can get pretty far down the road looking at the diligence. And you could probably eyeball that diligence and get a pretty good sense pretty quickly as to whether your program or the structure of your proposed program is viable in any particular jurisdiction. Les, I wonder if I could even just frame this a little bit within the broader work that I think so many of the people in the audience are doing these days, because what we know is that the international telemedicine, the international RSO opportunity, the international patient opportunity, that's sort of like it's one service line, right, within such a broad portfolio of cross-border projects that U.S. hospitals are doing these days. I mean, the hospitals are expanding their global footprint in ways that were unheard of just 10 or 20 years ago. And it's a trend that is growing. And Jared, you're at the center of this too. I mean, in some ways, hospitals are sort of racing to build their global footprint. And it's everything from advisory and consulting projects, like helping foreign governments and foreign companies structure their healthcare systems, or advise on how to build the latest and greatest emergency medicine center. So it's advising on best practices in clinical operation and care models and quality initiatives. But it's also everything from data initiatives, finding ways to harness all of the rich repositories of patient data that's out there and to combine it into one
research.
One area, research, obviously a lot of visiting physician programs right now. I feel like every day we're working on a visiting physician program whereby a foreign hospital or a foreign government is paying for U.S. citizens to be abroad for 1 to 2, 3 weeks a year to help with particularly complex clinical care situations. Obviously, global education and training programs. There's a lot of marketing going on as well in terms of building visibility and branding of the U.S. hospital in foreign locations, obviously to attract patients, but also for other reasons as well, because it's really good for the U.S. institution to be on the radar of the Foreign Ministry of Health, to refer, to refer physician, to refer patients, to refer for specialized care that is not available locally. And so combining all of that with the telemedicine opportunity, I think it's important to say that, because it is all these things together now that is making the U.S. hospital sort of a much more globalized endeavor than ever before.
Yeah, I totally agree.
So it sounds to me like there's a whole diversity of business models that hospitals might consider in doing business overseas, from the traditional, we want to reach out and encourage patients to come visit us and do procedures locally, to other avenues. Are there any particular business models that you've seen that are really interesting that people should consider that perhaps they're not considering these days?
I can talk about one that we're seeing more and more of that I think is really smart. We're seeing, I think, it become more popular, is the global care network model. So Cleveland Clinic connected, the Mayo Clinic Care Network. I believe Dana-Farber has one as well, where international and domestic hospital sites pay to be a part of US hospitals network, and they're able to share expertise, case review. Might get logo usage and able to tap into education and training programs, and having that be a service that is rolled out kind of with a name affiliation, I think we're seeing increasingly, especially some of the big players. Bill, what do you think?
I mean, you've mentioned the networks. I mean, yes, and there are different flavors of global networks, right? There are some very formalized ones that we have put together through contractual documentation and network agreements, but there are other more informal global networks
Right.
that U.S. institutions are taking advantage of based on development of relationships over a period of time. So there's many ways to think about a network, but you're right. There are some networks that are very sort of logo and branding focused, whereby it's a real point of prestige for that
Mm-hmm.
foreign hospital to be
Right.
in a network with this particular U.S. hospital that is making available the opportunity to use the U.S. hospital's name and brand in very specific targeted ways. I mean, look, this is not
Mm-hmm.
necessarily putting your logo on the side of a hospital in Bahrain.
Mm-hmm.
This is allowing certain care specialists to use the U.S. hospital's name in certain ways. So lots to talk about there in terms of how those could be set up. What we are seeing an enormous amount of advisory and consulting projects whereby foreign providers, foreign hospitals, foreign companies, foreign governments are coming to the U.S. institutions, and sometimes these are based on relationships that have been developed over time, and really put a lot of resources into these relationships. But they're coming to the U.S. hospitals. And they're saying, help us establish the first eye clinic in this
Yeah.
part of the world, or help us build out the first pediatric center of excellence in this
Mm-hmm.
particular country. And we're gonna pay you for that. We're gonna pay you for that because we want the U.S. Style public health service here, and U.S. has the best. We want the U.S. style, so replicate here what you've done in the U.S. Now, obviously, that's hard to do, and that is a very sort of document-heavy transaction to get those things right. But there is a lot of revenue flowing through those agreements these days. But those are sort of bigger, splashier projects. Um, we're also seeing a great deal of focus on U.S. institutions marketing and advertising
Mm-hmm.
themselves abroad, whether
Yeah.
it's in Bermuda or whether it's in Southeast Asia. The school hospitals want to be able to have some name recognition in these parts of the world for lots of different reasons. One being for flow of patients, but there's other reasons as well.
Yeah, and one of the ways that we're seeing, Bill, to add on to that we're seeing that happen to get the name recognition out there, is we're seeing more and more in-country offices opening in new geographies where they'll have a patient referral office or consulting a project office in a new country. I mean, we've seen new offices just in the past year set up in Uruguay, Nigeria, like all over.
Mhm.
So I don't want to go away from this topic without talking about governmental relationships. And I know, Bill, that's a role that you often play with some of these client hospitals of yours. But what do you recommend, or in general, what do you see from hospitals forming relationships with embassies or with governmental agencies within some of these foreign jurisdictions?
Yeah, well, I'd love to bring Jared into that because Jared, you are one of the experts in developing that sort of business with non-US governments and entities, and you've been at the center of that for a long time. And then I can come in and talk about some of the parameters that one ought to set up in order to do this lawfully, and to do it without without going too far afield ethics in terms of how these relationships ought to be structured. So, Jared, why don't you start, and then I'll come in.
Sure. Yeah. So I will say so many of our member hospitals, as I mentioned, have deep existing relationships, in particular with some of the Gulf governments. So with the Saudi embassy, with the Emirati embassy, Kuwait, et cetera. But it also extends beyond those as well. Like we see pretty deep relationships in some smaller countries, more on our side of the world, like Bermuda, Bahamas, Cayman Islands. But I would say the bulk of it's more than 50%, I think, at this point. But the bulk of the international patient referrals are really still coming from the Gulf to our members. So now I will say that, so the volumes are declining overall, slowly, less so in pediatrics. Pediatrics, the volume has not declined year over year as much as some of the adult volumes, but we are seeing increasing patient complexity, higher case mix index, and telemedicine increasingly with some of the Gulf payers being and remote second opinion services being an integral and expected component of the relationship that many of our members have with these, their primary Gulf referrers. Coming to mind immediately would be Department of Health Abu Dhabi and Qatar especially. Those relationships continue to deepen. As Bill mentioned, we're seeing very large new collaborations with some of these governments, in particular in areas like pediatrics, rehabilitation, I would say it seems like telemedicine is almost an expected component of many of these relationships now. So for those that aren't able to do it, I think they are at a disadvantage with some of these primary Gulf payers.
Bill, you want to jump in and top that off?
Sure. Yeah, I mean, Jared is right. I mean, as these big projects take off, telemedicine is obviously one component. It continues to be of high interest because virtual services is in demand around the world. As we look at organizations in the US pursuing these relationships with foreign governments or foreign state-owned enterprises, and let's be honest, that this tends to be where the deep pockets are outside the United States. It's the work directly for the government, the work for state-owned companies. You have to be really careful in terms of how you approach that relationship, how you cultivate that relationship, and how you paper it at the right time. Because doing business with foreign governments and foreign companies can be a bit of a tricky business unless you've got the right risk management protocols in place. So obviously, whenever you're doing that kind of work, you get very concerned about making sure you understand the corruption law both in the U.S. and in the local jurisdiction. That means not just understanding the U.S. Foreign Corrupt Practices Act, but also understanding what is allowed from a local host country law perspective in terms of developing business with local governments. And there can be a relatively complex and opaque set of laws in various countries in terms of what constitutes a conflict of interest or what constitutes corruption. So one has to be just mindful of that. And quite a few U.S. institutions that are now engaging in more and more cross-border work are developing very clear and robust compliance programs for anti-corruption. And whether that's very clear policies and procedures, whether that's training and awareness, whether that's new contract provisions with your foreign partners and business collaborators, whether that is certain whistleblower protections and internal reporting mechanisms. We're seeing a lot of diligence now being done on potential foreign collaborators before those relationships really blossom. There have been plenty of perhaps too many situations in which relationships have developed only for folks to learn after the fact that the people associated with the foreign company or the foreign entity not are not particularly savory people, and it's really not becoming of a U.S. institution to be involved with them.
Mhm.
So doing that kind of diligence, that upfront diligence, obviously the basics is restricted party screening and all of that, but doing some more diligence to make sure you understand the foreign counterparts' finances, their leadership, their reputation, their litigation history, all of those things combined will feed into whether it makes sense to get into a relationship with the foreign business collaborator, the foreign hospital, the foreign government, um, and whether that should be a short-term relationship or whether it could be a potential long-term marriage. Really depends on how that diligence comes out. And there's all sorts of other things to be aware of as you build these bridges to foreign governments, such as being cautious when using intermediaries. There's lots and lots of people running around who like to say, I can connect you. I can be your middle
Right.
person. And some of those people are trustworthy and some are not. And how you gauge that, you may need some help to gauge that because some of these folks are very convincing, whether they're a company or they're a consultant. They're very convincing, and they tend to tell you that they have influence to help you get in front of particular foreign hospitals or government officials. And it may not always be the way that you think that they're doing it. So
Yeah, Bill,
again,
I think that's you hit the nail on the head, and I think we see our member hospitals both coming to us as USCIPP to on an informal basis to ask, do you know this entity? Asking the broader membership if they have if their colleagues have any insights into X vendor or whatever entity, but then also doing more formal due diligence and analysis with a firm like Hogan Lovells if you're really serious about a potential project partner.
Great. Interesting area. Probably a really important one as well. But if we could for a minute, I'd like to just move us back into, I'm going to call this a quick data dump area. I'd like to talk a little bit for our audience about licensure generally, data residency, and language, and then maybe talk a little bit about culture as well and how that might change. But let's talk about licensure for a minute. Obviously, licensure, US-based physician, not licensed in a foreign jurisdiction, potentially offering an opinion to a foreign resident or a foreign located person. How do we go about doing that? Or what is the general rule for handling that?
It depends.
I'm not surprised by that answer. Tell us what it depends upon.
I can maybe start, Bill, and you can maybe hop in as well. So we, as USCIPP, recently updated our reports for Qatar, Chile, Costa Rica, Panama, Kuwait, and China. Looking at some of these recent developments in these markets that we've looked at in the past. So provider to provider, international RSOs often allowed. Conditions vary. I wrote down an example of Chile. So the patient is involved at any point in a peer-to-peer consultative process for an international RSO. The general rules regarding the practice of medicine become applicable. Now, that is not necessarily the same in all countries, but I would say as a general broad rule, provider to provider is easier. The patient may not always be able to be present or involved. And in fact, many countries, they're explicitly not able to be involved, but you can sometimes skirt around the practice of medicine issue there. Bill, thoughts?
Yeah, I mean, there are so many permutations of these sorts of
Very
programs,
complicated.
right? And so what I may think of as direct to patient or doctor to doctor may not be quite what you're thinking
Right.
in terms of it. And so it is important to get to the specifics as to the structure and the model in order to get this right. But it is true that, I mean, look, at the highest level, what we know, right, is that the location of the patient is what matters.
Right.
And sometimes it's not just the country in which the patient is in, but it's the province in the country in which the patient is in.
Canada.
Canada is a great example, right? Ontario is very different from British Columbia, which is very different from Quebec in terms of how this is regulated. And so getting to that level of specificity is important. But if you were to do a survey around the world, I think as Jarrett was getting at, peer-to-peer, physician-to-physician style virtual consultations tend to be more tolerated, much more tolerated than than a direct-to-patient
Mhm.
style program. Um, but look, there are many different kinds of direct-to-patient programs. Some are actual diagnosis and treatment, but others are much more like education focused. And so,
Right.
one has to get to that level of granularity to truly understand how this is regulated in a particular country. And then, even as we're talking about physician-to-physician programs being potentially less regulated, even those take many different shapes in terms of how data, for instance, gets from one place to another.
Mhm.
What is exchanged? What is the work product? What is the revenue? And what is the implication of the revenue stream? And from who is the revenue coming, whether a hospital or an insurance provider or some other third party? So it does get complex in terms of how the individual facts are regulated in any particular case.
Yep. So you touched on data for a minute, and I just want to bring up just a scenario for you. We're often seeing our hospitals surprised that even with patient consent, the PHI, or the private health information of a patient in a geography, is not permitted to cross country borders. Is that a surprise to you, or is that more of a rule in more countries than we know?
Well, in classic lawyer response style, I mean, it depends, right? um, to take it to a higher level, right? We all know, and anyone who works in this area knows that the proliferation of data privacy regimes has been one of the defining trends of cross-border anything in the past several years. I mean, obviously with GDPR, we all sort of started to get used to this. But now, yes, there are various countries that are taking an even tougher tone when it comes to data, but also but certain kinds of data, right? You will go to places like Zambia, for instance, when in certain situations, sensitive personal health data cannot be taken out of the country. It must be stored at all times in the country. Same thing with certain data out of Saudi Arabia. Depending on the circumstance, there are types of data that simply cannot leave the country, period. It must stay. And so, I mean, you're right, Les. I mean, we've got to be careful painting with a broad brush, because I couldn't say that in this country you should never and cannot ever take data out, even with consent. I think it really does get to a level of specificity about the type of program and the type of data and the type of model, and whether regulatory approvals are possible. Before we can make some definitive statements there.
And I'll comment, Bill. I think that when we've updated our legal due diligences over the past year, especially, but for 2 years really, that we've seen the most substantively altered parts of our analysis is the data privacy localization section of the report, often completely redone. Much deeper analysis for new rules in some of our updates.
Yeah, so data residency is something that could catch us if we're not careful. I think that's a fair statement. There was a question that was raised that's very relevant to this, which is if a hospital is using a third-party case management company, a concierge, if you will, does that get them off the hook for any of this stuff?
Well, I'd like to see the contract with the case management company, but look, I think we all know that as providers, as hospitals, it really is our um, responsibility to ensure that if one of our provider, if one of our physicians or even nurses are practicing their profession in a particular country and it requires licensure or some sort of registration that we ensure we do that regardless of whether a third party might be involved in the project.
Fair. So no webinar talking about technology or data would be complete without somebody asking a question about AI. So does AI tip the scales? And maybe we can even refer to this related to language. So translation, which is now one of those popular things in AI, is there anything that's going on there that we should be aware of that's specific to cross-border?
I can comment here.
Please.
We are seeing a proliferation of medical records translated using AI, and they are wrong, mistranslated, poorly translated. They did not go to a professional translation company, and they used AI, and it is causing many issues.
Well, it comes up a
point,
lot. Sorry, Les.
I was going to say, maybe I'll point to you, Bill, and just say, and whose problem is that?
Well, that's where I was going, right? So this is, I mean, it comes up a lot when you're negotiating remote second opinion agreements with a foreign hospital, and I feel like I'm seeing these every day. Um, when you're dealing with a country that where English is not the primary language, or at least where medical records are often not kept in the English language, one has to address in the contract whose responsibility is it going to be to to translate medical records. And as Jarrett was saying, you could do a machine learning translation. You could do a machine translation, that is, but that doesn't mean it's going to be right. And you know, it's expensive to go and get certified translations of thick EMRs, and so it does need to be addressed between the parties to these transactions. It can be a point of discussion and negotiation, undoubtedly, and it may depend too on the type of remote opinion that we're talking about. There are some relatively low risk specialties that are the subject of RSOs, and there are some very, very high risk ones where it would be irresponsible to not have a certified translation available to you. And so again, I hate to say it depends, but I think the message here is that it is very important to take this seriously.
So Jared, I'm gonna look to you and just to give us a generalization of that. Do most hospitals push that back and say, please translate into English before it comes to
Yes.
The physician? Okay.
Yes. I can't even think of any off the top of my head that would not require the medical records to be already translated in English. And the hospitals often do provide, recommended or vendors that they work with. But it is the responsibility of the patient to get the records in English to the U.S. hospital.
Great, that's helpful. So as we're coming into the last 10 minutes that we have here, I want to get very specific, both Jared and Bill, for how does a hospital or an entity engage each of you in your areas of expertise to get the kind of help that they need. So let's start with USCIPP and NCHL. So let's say there are many of your members in the audience today, but let's say somebody's not a member today. What would what could they expect from you, and what should they try to reach out to get from you?
They can expect a host of different ongoing touch points, engagement with our team. We have several different verticals that we focus on throughout the year: benchmarking, survey, data collection. We do an international patient experience initiative, our telemedicine and RSO work here. market analysis. We, as you had alluded to, we take international delegations of U.S. hospitals abroad to do international business development events. We're taking a group of 9 hospitals to Oman in October. USCIPP also works with many of the show organizers of prominent conferences where our members like to attend and present, and we're able to get speaking slots for physicians and other leaders from our member hospitals at some of these really important conferences. Disseminating information about geopolitical news, and also collecting ongoing, not just benchmarking data, but ad hoc data from members as sort of issues come up. Working with key stakeholders, the US government, international governments, to try to both bring business to our members and make sure that their business operations are unimpeded as best we can. If we're thinking about some of the visa issues we've been having, we've been trying to engage with the US government on that. But it's a very collaborative group, and I'm really highly engaged and a pretty high touch person, and I think my entire team is as well.
Great. So there's a lot of places that hospitals can get touch points within within USCIPP and NCHL.
And we have it's an annual membership program. So members can join, at any point in the year if they would like. Our annual meeting as well. That's a favorite of our members. Also in December in Florida, we have the USCIPP conference where our members get together and share best practices, and look forward to it.
And where is that conference this year?
It's going to be at Paley Institute in Florida, in West Palm Beach.
Great, terrific. And so, Bill, I know a lot of the client companies of USCIPP get the if they subscribe to it, get the due diligence that you've done, the general stuff. But there's got to be more that they need. How do they engage somebody like Bill or somebody at Hogan Lovells?
Yeah, so first let me just vouch for the quality of programming that USCIPP puts out, whether it's at the annual conference or the consistent touch points, as Jarrett was mentioning. I would encourage anyone who's not a member of USCIPP to become a member in some way, shape, or form. So we at Hogan Lovells, we're blessed to have a very large practice that focuses on colleges, universities, academic medical centers, hospitals, and research institutions. And for the past 20 years, I think we've had the opportunity to work with most of the USCIPP members and many, many more U.S. hospitals from east to west and north to south. And what we do at Hogan Lovells, being a big global law firm, right? We work on every possible issue, honestly, that comes up at these institutions, whether it's related to government funding or whether it's related to research or Medicare, Medicaid style issues, reimbursement issues, all the way, of course, to all the cross-border work, which is where I spend most of my time, is the international and global endeavors of most of these nonprofit institutions. And so we work across the board on growing and planting these projects around the globe. For virtually every style of international initiative, whether it is a research collaboration, a data-focused initiative, a patient recruitment initiative, a marketing initiative, or even a telemedicine or remote second opinion initiative. We sort of from the beginning to end, from the diligence, from the initial diligence on your foreign partner, all the way across through the contracting, through the issue spotting, through the regulatory advice. That's how we operate. And so we typically work directly with the Office of General Counsel at the various hospitals, and with them in the loop, we work with everyone from physicians to program managers to directors of units to try to help them grow and protect their international business.
And I might just comment also, and I'd like to just vouch for the impeccable quality of Hogan Lovells' work over the years. Bill, I think that you are one of the favorite partners that we've ever worked with over the years. And I honestly cannot think of many other partners or firms that have done better work for us. So
thank you, Jan. It's very kind.
Great. Good reinforcement on both sides. Well, terrific. So we're coming to the end of our time. I really do appreciate your participation, Jared and Bill. This is great information. I know it's just scratching the surface of what somebody really needs to engage in to do this in real life, but it is a ton of information that you provided. It gives us a really good starting point, at least, for how to go about this. And I'm sure that the members of USCIPP get a lot of benefit from USCIPP, and those that engage you as well, Bill, get a lot of benefit from there. And I think this is a terrific introduction to that. If there are additional questions, I believe there's one more screen that we can share. How do you get in touch with any of these organizations? Obviously, for Purview, you can get in touch with us on our website, purview.net. There's the screen. You can become a member of USCIPP by emailing uscip@nchl.org, and you can get directly to Bill at his email address that's shown on the screen as well. There is a white paper that you can pick up, The Legal Reality of Issuing Second Opinions for Out-of-State Patients. That deals with domestic issues related to that. And we at Purview have another webinar coming up in, it looks like November 12th of this year, in which we're going to deal with the domestic licensure update. So that will be all things licensure and how that relates to doing business amongst the various states and regions of the United States. So thank you again, panelists. Thanks for joining us today. We do appreciate it, and hope you have a great end to your summer and a terrific start to the fall season. Thank you.
thank you, everyone.
Thank you.